got a whole practice team meeting coming up at the end of March, which will include reviewing how we help each other and our patients to look out for signs of sepsis. This is a quick overview to help us think about what to focus on to help each other. Sepsis is thankfully rare, but a serious complication of infection. The Sepsis Trust does a lot of work promoting awareness and education. Please have a look at their website. General awareness has been helped with recent stories in Coronation Street, Call the Midwife and The Archers. The excellent Trust Me I'm a Doctor series on BBC Two has a very good 6-minute clip which is well worth watching. Here's a recent film about a survivor of septic shock living with life-changing consequences. Sepsis is one of the medical emergencies we all need to watch out for. It can be more difficult to spot than the other medical emergencies such as heart attacks, strokes, blood clots, severe asthma attacks and so on. It happens when the body's immune system is weakened and or an infection is very severe. Instead of recovering from an infection as the body normally does, the immune system can go into overdrive. It can be triggered by any infection, but most of the time from bacterial infections in the lungs, urine, abdomen organs and skin. There are around about 37,000 deaths from sepsis in the UK per year, more than deaths from breast, prostate and bowel cancers put together. The word sepsis comes from an old Greek word for decay. It used to be known as septicemia or blood poisoning. It's life-threatening, but if caught early, the outcome is good. If not picked up, it can lead to shock with failure of the body's organs and then death. There are 250,000 cases per year in the UK, and of the 37,000 deaths, it's estimated that perhaps 10,000 could be prevented. When in septic shock, the risk of death increases 7.6% for each hour delay in treatment. 70% originates outside of hospital, and survivors can come to significant harm, such as stress, memory loss, and amputations. A quick mention of the body's immune system. It's normally amazingly good and works very well. Normally the body recovers from infection. Normally infections aren't serious, partly due to the effective immune system. Less than 1 in 100 children coming into a GP surgery with a feverish illness have a serious infection, but picking out that one child in 100 can be difficult. We generally expect young children to have 6 to 10 virus infections per year and recover normally due to the immune system. Here are the cells in the blood that fight infection. They're listed at the end of a full blood count result. The 10 to the 9 means a billion, so this person has 5.5 billion neutrophils per litre. We produce around 10 billion neutrophils per day. They only last for a few hours. There are also the lymphocytes. Some of those produce antibodies, which is part of the immune system that remembers infection and how many vaccines work. Here are some electron microscope pictures of the blood's immune cells. What happens when the body senses infection? The blood flow to that area of the body increases. The blood vessels widen up and leak out the immune blood cells that go and deal with the infection. If it's near the skin, such as on a finger, you can see the redness of the inflammation as the blood flow is increased and the blood's immune cells leak out and do their job. What happens in sepsis is that the body detects risk all over. The immune system goes into overdrive. All over the body, the blood vessels widen and leak, and the blood pressure falls. With less blood to the vital organs of the body, they start to fail. Less blood to the brain causes confusion and changes in mental state. Less blood to the skin means it goes mottled, similar to your skin if you're out in the cold frosty weather in shorts. Here's more detail about infections leading to sepsis. Half of them are lung infections or pneumonia. Who Who's mainly at risk of sepsis? It can be anyone, but it's mainly the very young and the very old, under 1 year and over 75. Anyone who is frail and has one or more long-term conditions such as diabetes, anyone whose immune system is affected by illness such as sickle cell disease or not having a spleen, or treatments such as steroids, chemotherapy, or the immune suppressing drugs used in autoimmune diseases such as rheumatoid arthritis. Anyone who's had trauma or surgery or an invasive procedure in the last 6 weeks. Anyone with an indwelling line into a blood vessel or a urine catheter. Anyone with a break in the skin, such as cuts, burns, blisters, or skin infections. And anyone who's pregnant or has been pregnant in the last 6 weeks, especially if they have diabetes or had an operation or in contact with strep infections, respiratory infections or scarlet fever, or signs of uterus infection. This chart shows that most deaths are under 1 and over 75. The deaths per 1,000 is a log scale which flattens the chart down. Many elderly people at the end of their lives will have end-of-life care plans where they've made an informed choice that due to severe frailty and other illnesses causing the end of their life, they will choose to avoid intensive treatment for sepsis, as it will not likely make a difference to their survival and quality of life. Assessing people with suspected infection involves checks on the likely source of infection, to make observations, especially with their behaviour, breathing and circulation, and to check out any risk factors. There are 6 main areas of assessment: behaviour and history, breathing, circulation, skin, temperature and urine. With behaviour and history, slurred speech, confusion, can't say what's wrong, acting strangely, never felt this ill before, or think they're going to die. It's important, as always, to listen to carers and relatives who know best what the person is normally like, and also check the risk factors in the history. Breathing, it can be fast at rest or cannot speak sentences due to fast breathing. Circulation, feeling lightheaded, faint, cold hands and feet, muscle pain, blurry vision. Skin can be mottled or discoloured, new rashes that don't disappear when pressed. Temperature, this can cause extreme shivering. High temperature may be present but may be absent and a low temperature instead. Urine, passing their urine in 12 to 18 hours. The Sepsis Trust has put some of these into posters to fit the letters of the word sepsis. So S for slurred speech or confusion, E for extreme shivering or muscle pain, P for passing no urine, S for severe breathlessness, I for it feels like you're going to die, and S for skin mottled or discoloured. Here's the full Sepsis Trust poster. In hospital, a predictor of a person's outcome, called the Sepsis-Related Organ Failure Assessment, or QSOFA for short, is based mainly on just 3 factors: blood pressure, behaviour, and breathing rate. NICE, the National Institute of Clinical Excellence, have published guidance on the assessment of possible sepsis, which is NICE guideline number 51. And this BMJ article has usefully condensed it into a quick reference guide, which is obviously not possible to read on this slide. But there are many guides of the NICE guidelines, and GPs have any number of these to hand. The main thing is to have it printed out or saved on the computer so you can read it without relying on the internet working and not having to use a magnifying glass. As with all guidelines, they need to be balanced with clinical judgment, I like the BMJ format, and here's the behaviour and history with the age group columns. Red indicates high risk factors and orange indicates moderate to high risk. Here's the breathing, respiratory rate and also oxygen saturation, which is adjusted according to whether the person has COPD and normally lower oxygen saturations than normal. Circulation, including capillary refill in the under 12s. Pulse range will be adjusted by clinical judgment depending on medications such as beta blockers. Also, many female patients in their 20s have a systolic pressure under 100, so we need to adjust to whether it's 40 degrees of mercury below the patient's normal systolic pressure. Skin colour, whether mottled, blue lips, rashes, reduced skin turgor in kids. Temperature and urine. After 6 months, it's temperature under 36, suggesting risk, rather than high temperature, and reduced urine output. Over 12, no urine in 18 hours is high risk, and within 12 to 18 hours is high to moderate. And then what to do with using clinical judgment, as always. As conveyance to hospital is under 1 hour from here, would not normally start parenteral antibiotics except in cases of meningococcal sepsis, and it's worth checking the specific NICE guidelines about this. This is the National Early Warning Score, shortened to NEWS, which was developed by the College of Physicians, and its main use is in communicating severity when speaking to ambulance service and the receiving medical team. A score over 5 suggests need for emergency admission. How we safety net people with infections who aren't needing hospital admission is crucial, and this is something to share at the practice meeting. Here's the Sepsis Trust's public advert for children, similar to adults, but also includes unexpected seizures. It's very similar to page 7 and 8 of the When Should I Worry booklet that John has been promoting for parents and carers of young children. And the many having these symptoms should be checked in GP surgeries or through 111 out of hours to assess their risk. The role of general practice in sepsis. Although thankfully it's rare, we should always have it at the back of our minds, especially as in general practice we often see illnesses in their early stages. We should be ready for prompt assessment and management with good communication. We need to be safety netting and giving clear advice to patients, and this is something we may want to focus on in the practice meeting. We have a role in prevention of infections such as vaccination. The pneumococcal, meningococcal, influenza and Haemophilus influenzae or Hib are especially effective in preventing potential sepsis. And also trying to stem the looming crisis of antibiotic resistance by avoiding inappropriate antibiotic prescribing. And NICE is obviously helpful in guiding us in this. Here's the EMIS web template called Sick Patient Evaluation, which can be useful as a reminder of the checks we need to make and document. And in the meeting we could review what makes EMIS bring up these alerts, which can be useful but also quite annoying, particularly, for example, if someone normally has a low blood pressure. Here's some useful links. Please flag up anything else that would be helpful for the whole team. Thanks very much.